A hiatal hernia. A hiatal hernia is when the upper part of the stomach pushes into the chest through an opening in the diaphragm, a muscle that separates the chest from the abdomen. 2. What symptoms are associated with hiatal hernia? Heartburn, a burning sensation in the chest pain, and dysphagia, difficulty swallowing. 3. How is hiatal hernia diagnosed? Hiatal hernia can be diagnosed using endoscopy and barium studies. 4. How is hiatal hernia treated? First treatment is weight loss and proton pump inhibitors, PPIs. If symptoms continue, surgery may be needed. 5. What is dysphagia and why is it important? Dysphagia is difficulty swallowing and odonophagia is pain while swallowing. Both can cause weight loss. 6. What are alarm symptoms and why are they important? Alarm symptoms include weight loss, blood in stool, and anemia. These may indicate serious issues like cancer. 7. What is achalasia? Achalasia is when the lower esophageal sphincter, LES, cannot relax, causing difficulty in swallowing both solids and liquids. 8. How is achalasia diagnosed? Achalasia is diagnosed using barium esophagram, manometry, and endoscopy. 9. Can achalasia be cured? No. Achalasia cannot be cured because the nerve damage cannot be fixed. Treatments only help relieve symptoms. 10. What are the treatment options for achalasia? Treatment options include pneumatic dilation, surgery, myotomy, and Botox injections. Here are the next 20 questions and answers. 11. What is esophageal cancer, and what are the clues to diagnose it? Esophageal cancer causes difficulty swallowing that starts with solids and progresses to liquids. Risk factors include age over 50, long-term GERD, and alcohol or tobacco use. 12. How is esophageal cancer diagnosed? Esophageal cancer is diagnosed using endoscopy with biopsy, barium studies, CT MRI scans, and PET scans. 13. How is esophageal cancer treated? Treatment includes surgery, chemotherapy, radiation, and stent placement. 14. What are esophageal spastic disorders, and how are they different from esophageal cancer? Esophageal spastic disorders like diffuse esophageal spasm and nutcracker esophagus cause chest pain but don't involve cancer. They are diagnosed by manometry. 15. What is eosinophilic esophagitis and how is it diagnosed? Eosinophilic esophagitis is an inflammatory condition diagnosed by endoscopy and biopsy showing eosinophils. 16. What is Steakhouse syndrome? Steakhouse syndrome refers to dysphagia caused by a Schatzky ring, especially when eating solid foods like steak. 17. What are Schatzky rings? Schatzky rings are a ring-like narrowing in the lower esophagus, often caused by acid reflux or scarring. 18. What are the main symptoms of Schatzky rings? The main symptom is intermittent dysphagia, meaning difficulty swallowing solids that comes and goes. 19. How is Schatzky ring diagnosed? Schatzky ring is diagnosed using barium studies. 20. How is Schatzky ring treated? Schatzky ring is treated with pneumatic dilation, an endoscopic procedure that stretches the esophagus. 21. What is Plummer-Vinson syndrome? Plummer-Vinson syndrome is a condition where thin webs of tissue in the upper esophagus cause dysphagia associated with iron deficiency anemia. 22. How is Plummer-Vinson syndrome different from Schatzky ring? Plummer-Vinson affects the upper esophagus and is linked to iron deficiency, while Schatzky ring affects the lower esophagus and is related to acid reflux. 23. How is Plummer-Vinson syndrome treated? Plummer-Vinson syndrome is treated with iron replacement therapy. 24. Why is Plummer-Vinson syndrome linked to iron deficiency anemia? The exact reason is unclear, but the iron deficiency is not caused by blood loss. 25. How can Plummer-Vinson syndrome lead to squamous cell cancer? The chronic irritation caused by the esophageal web can transform into cancer over time. 26. Why are barium studies helpful for diagnosing Schatzki ring and Plummer-Vinson syndrome? Barium studies can show the narrowing, ring or web, in the esophagus on X-rays. 27. What is a peptic stricture and how is it related to Schatzki ring? A peptic stricture is scarring in the esophagus caused by acid reflux, and Schatzki rings are a specific type of peptic stricture. 28. Why is Schatzki ring associated with hiatal hernia? A hiatal hernia allows stomach acid to reflux into the esophagus, leading to the formation of Schatzki rings. 29. Why does treating Plummer-Vinson syndrome with iron sometimes fix the lesion? When the anemia is treated with iron, the body can repair the esophageal web. 30. Why are Schatzki ring and Plummer-Vinson syndrome grouped under rings and webs? Both involve abnormal tissue in the esophagus that causes difficulty swallowing. Are the next 20 questions and answers. 31. What is Zenker diverticulum? Zenker diverticulum is an outpocketing of the posterior pharyngeal constrictor muscles in the throat. 32. What are the symptoms of Zenker diverticulum? Symptoms include dysphagia, halitosis, regurgitation of food particles, and aspiration pneumonia. 33. Why is Zenker diverticulum associated with bad breath? Food particles can get stuck in the pouch, where they rot and cause severe halitosis. 34. How is Zenker diverticulum diagnosed? Zenker diverticulum is best diagnosed using barium studies. 35. How is Zenker diverticulum treated? Zenker diverticulum is treated with surgery to repair the diverticulum. 36. Why are nasogastric tube placement and endoscopy dangerous in Zenker diverticulum? These procedures can accidentally cause perforation of the pouch. 37. What is the main problem with the esophagus in scleroderma? In scleroderma, the lower esophageal sphincter, LES, has decreased pressure and can't close properly, leading to reflux. 38. How is scleroderma diagnosed in esophageal disorders? Scleroderma is diagnosed using manometry, which measures pressure and movement in the esophagus. 39. How is esophageal reflux in scleroderma treated? Reflux in scleroderma is treated with proton pump inhibitors, PPIs, just like in other reflux conditions. 40. What is a Mallory-Weiss tear? A Mallory-Weiss tear is a non-penetrating tear in the mucosa of the esophagus caused by severe vomiting or retching. 41. What are the symptoms of a Mallory-Weiss tear? Symptoms include bright red vomiting, hematemesis, and black stool, if blood is digested. 42. How is a Mallory-Weiss tear treated? Most tears heal on their own, but severe bleeding may require epinephrine injection or electrocautery. 43. How is Mallory-Weiss tear different from Boerhaave syndrome? Mallory-Weiss tear is a shallow tear in the mucosa, while Boerhaave syndrome is a full-thickness tear of the esophagus. 44. What is cannabinoid hyperemesis syndrome? Cannabinoid hyperemesis syndrome involves repeated episodes of nausea, vomiting, and abdominal pain in people who use marijuana frequently. 45. What unusual behavior might suggest cannabinoid hyperemesis syndrome? Patients often feel better after taking a hot shower or bath. 46. How is cannabinoid hyperemesis syndrome treated? Treatment involves stopping marijuana use and using medications like antiemetics or benzodiazepines. 47. What is the key to diagnosing cannabinoid hyperemesis syndrome? The key is a history of regular marijuana use combined with symptoms that improve with hot showers. 48. What is the epigastric area? The epigastric area is the part of the abdomen just below the xiphoid process and between the ribs above the umbilicus. 49. How common is epigastric pain? Epigastric pain occurs in about 25% of the population at some point. 50. What is the difference between pain and tenderness in the epigastric area? Pain is a sensation the patient feels, while tenderness is increased pain felt when the doctor presses on the area. Here are the next 25 questions and answers. 51. What conditions are more common in hospitalized patients with epigastric pain? Hospitalized patients with epigastric pain are more likely to have ulcers, biliary disease, pancreatic disease, cancer, and gastritis with bleeding. 52. What is the most accurate way to find the cause of epigastric pain? The most accurate test is endoscopy, where a doctor uses a camera to look inside the stomach and take biopsies if needed. 53. Why are barium studies less accurate for diagnosing stomach problems? Barium studies may show abnormalities but cannot provide biopsies and have limited accuracy compared to endoscopy. 54. When are barium studies more useful? Barium studies are more useful for diagnosing problems in the esophagus, but not the stomach. 55. What is the first-line treatment for epigastric pain? The first-line treatment is proton pump inhibitors, PPIs, such as omeprazole or pantoprazole. 56. Are all PPIs equally effective? Yes, all PPIs are equally effective in treating epigastric pain. 57. What are H2 blockers, and how effective are they? H2 blockers like ranitidine and famotidine are less effective than PPIs, but still work in about 70% of patients. 58. How do liquid antacids compare to H2 blockers? Liquid antacids work about as well as H2 blockers in reducing stomach acid. 59. What is misoprostol, and why is it not used for epigastric pain anymore? Misoprostol was used to prevent NSAID-induced stomach damage, but became obsolete when PPIs were introduced. 60. Why is misoprostol always a wrong answer on tests? Misoprostol is outdated and much less effective than PPIs, making it irrelevant for modern treatment. 61. Why might tenderness in the epigastric area be less common than pain? Tenderness requires a physical exam, and not all patients with pain will have tenderness when pressed. 62. Why is it essential to biopsy during endoscopy for epigastric pain? A biopsy can confirm conditions like ulcers, gastritis, or cancer, which radiologic tests can't do. 63. How does endoscopy differ from barium studies in terms of diagnostic precision? Endoscopy is far more precise because it directly visualizes the stomach lining and allows for biopsies. 64. GERD stands for gastroesophageal reflux disease, a condition where the lower esophageal sphincter, LES, relaxes inappropriately, allowing stomach acid to move up into the esophagus. 65. What are common triggers that worsen GERD symptoms? GERD symptoms can worsen with nicotine, alcohol, caffeine, chocolate, peppermint, late-night meals, and obesity. 66. How do GERD symptoms typically present? The hallmark symptom is epigastric burning pain that radiates up into the chest. 67. What additional symptoms might a GERD patient report? GERD can also cause sore throat, bad taste in the mouth, hoarseness, and cough. 68. Why does GERD not have unique physical findings? GERD is a symptom complex, meaning it is primarily diagnosed based on the patient's description of symptoms, not physical exam findings. 69. When is GERD diagnosed based on symptoms alone? GERD is diagnosed without confirmatory tests when the patient has clear symptoms like burning, epigastric pain, radiating to the chest, and bad taste in the mouth. 70. When might 24-hour pH monitoring be used for GERD? 24-hour pH monitoring is used when the diagnosis of GERD is uncertain based on symptoms alone. 71. Why is endoscopy usually unnecessary for GERD? Endoscopy often shows nothing when GERD is limited to heartburn, pyrosis, without complications. 72. When is endoscopy indicated in GERD? Endoscopy is used if the patient has dysphagia, odonophagia, weight loss, anemia, or more than 5 to 10 years of symptoms. 73. What might endoscopy reveal in GERD? Endoscopy can show redness, erosions, ulcerations, strictures, and Barrett's esophagus in GERD. 74. What lifestyle changes are recommended for GERD? Patients should lose weight if obese, avoid alcohol, nicotine, caffeine, chocolate, pep. Here are the next 25 questions and answers. 76. What is the first-line treatment for persistent GERD symptoms or erosive esophagitis? Proton pump inhibitors, PPIs, are the first-line treatment for persistent GERD symptoms or erosive esophagitis. 77. Is there a difference in efficacy between PPIs? No, all PPIs are equally effective in treating GERD. 78. What treatments are available for GERD patients who do not respond to medication? If medications don't work, surgical or procedural options include Nissen fundoplication, endokinch, and local heat or radiation therapy. 79. Why do nicotine and alcohol worsen GERD? Nicotine and alcohol relax the lower esophageal sphincter, making it easier for stomach acid to flow back into the esophagus. 80. What is Barrett esophagus, and why is it significant in GERD? Barrett esophagus occurs when the esophagus lining changes due to long-term acid exposure, increasing the risk of esophageal cancer. 81. Why is barium swallow not helpful for GERD? Barium swallow only shows major structural abnormalities and doesn't diagnose GERD, which is a functional issue. 82. Why do some GERD patients develop hoarseness or a cough? Acid can travel up the esophagus and irritate the throat or vocal cords, causing hoarseness and coughing. 83. What is Barrett esophagus? Barrett esophagus is a condition where the normal cells in the lower esophagus are replaced by columnar cells due to long-standing GERD. 84. How long does it take for Barrett esophagus to develop? It typically takes at least 5 years of persistent acid reflux for Barrett esophagus to develop. 85. Are there specific physical or lab findings for Barrett esophagus? No. Barrett esophagus has no unique physical findings or lab tests. 86. What test is needed to confirm Barrett esophagus? Endoscopy with biopsy is necessary to confirm Barrett esophagus. 87. Why is biopsy indispensable in Barrett esophagus? The biopsy is critical because it detects dysplasia, which shows how abnormal the cells are and helps decide treatment. 88. What is the significance of columnar metaplasia with intestinal features? This type has the highest risk of progressing to esophageal cancer. 89. What is the annual risk of Barrett esophagus progressing to cancer? Each year, about 0.5% of people with Barrett esophagus develop esophageal cancer. 90. How is Barrett esophagus managed based on biopsy findings? Barrett alone is monitored with PPIs and rescoped every 2 to 3 years. Low-grade dysplasia is rescoped every 6 to 12 months. High-grade dysplasia requires endoscopic ablation. 91. What is gastritis? Gastritis is the inflammation or erosion of the stomach lining, also called gastropathy. 92. What are common causes of gastritis? Common causes include alcohol, NSAIDs, Helicobacter pylori infection, portal hypertension, and stress. 93. What is atrophic gastritis, and why is it important? Atrophic gastritis can lead to vitamin B12 deficiency. 94. How does gastritis typically present? Gastritis often presents with gastrointestinal bleeding without pain. Severe cases can cause epigastric pain. 95. What is the significance of coffee ground emesis? Coffee ground emesis indicates mild bleeding of 5-10 mm in the stomach. 96. How can the severity of bleeding in gastritis be assessed? The appearance of the bleeding from coffee ground to melena can estimate the volume of blood loss. 97. What tests are used to diagnose gastritis? Upper endoscopy is the definitive test, and H. pylori testing can identify bacterial infection. 98. What are the methods for testing Helicobacter pylori? Testing methods include endoscopic biopsy, serology, urea breath test, and stool antigen test. 99. What is the first-line treatment for gastritis? Proton pump inhibitors, PPIs, are the most effective treatment for gastritis. In 100. Are H2 blockers or sucralfate as effective as PPIs for gastritis? No, H2 blockers and sucralfate are less effective than PPIs. Here are the next 25 questions and answers. 101. When is stress ulcer prophylaxis needed? Stress ulcer prophylaxis is indicated in patients on mechanical ventilation, with burns, or with head trauma. 102. What is peptic ulcer disease, PUD? Peptic ulcer disease refers to ulcers in the duodenum, duodenal ulcer, DU, or stomach, gastric ulcer, GU. 103. Why is the name peptic a misnomer? It was mistakenly believed that the enzyme pepsin caused the ulcers. 104. Can you distinguish between duodenal and gastric ulcers without an endoscopy? No, you cannot definitively distinguish between DU and GU without an endoscopy. 105. What is the most common cause of peptic ulcer disease? The most common cause is Helicobacter pylori infection. 106. What is the second most common cause of peptic ulcer disease? The second most common cause is NSAIDs, e.g. ibuprofen. 107. What are less common causes of peptic ulcer disease? Less common causes include burns, head trauma, Crohn's disease, gastric cancer, and Zollinger-Ellison syndrome. 108. Do alcohol and tobacco cause ulcers? No, alcohol and tobacco do not cause ulcers but can delay healing. 109. What are the typical symptoms of peptic ulcer disease? Recurrent epigastric pain and rarely upper GI bleeding. 110. Can tenderness and vomiting confirm PUD? No. Tenderness and vomiting are uncommon and cannot confirm PUD. 111. What's the difference between duodenal and gastric ulcers? Duodenal ulcers have pain that improves with eating, while gastric ulcers have pain that worsens with eating. 112. Can you diagnose PUD based on symptoms alone? No. You need tests like endoscopy or barium studies to diagnose PUD. 113. What is the most accurate test for PUD? Upper endoscopy is the most accurate test for PUD. 114. Why is endoscopy preferred over radiologic tests for PUD? Endoscopy can detect gastric cancer and confirm H. pylori, while radiologic tests cannot. 115. What percentage of gastric ulcers are associated with cancer? About 4% of gastric ulcers are caused by cancer. 116. Is cancer found in duodenal ulcers? No. Duodenal ulcers are not associated with cancer. 117. What is the most accurate test for H. pylori? An endoscopic biopsy is the most accurate test for H. pylori. 118. Should non-invasive H. pylori tests be used before endoscopy? No. Non-invasive tests are unnecessary if endoscopy is planned. 119. How effective are PPIs for treating PUD? PPIs work in over 95% of cases, but won't prevent recurrence if H. pylori isn't eradicated. 120. What is the best initial therapy for H. pylori-associated PUD? A PPI plus clarithromycin plus amoxicillin is the best initial therapy. 121. What are alternative antibiotics for H. pylori treatment? If the initial therapy fails, use metronidazole and tetracycline, possibly with bismuth. 122. How is treatment success for H. pylori confirmed? Retest with stool antigen or breath test to ensure H. pylori is eradicated. 123. Should asymptomatic Helicobacter pylori be treated? No. Asymptomatic infections should not be treated. 124. How often is H. pylori linked to DU and GU? Duodenal ulcer, 80-90% of cases. Gastric ulcer, 50-70% of cases. 125. What is the only use of tetracycline in PUD? The only use of tetracycline is for treating H. pylori infections. Here are the next 25 questions and answers. 126. What should be considered if there's no response to DU treatment with PPIs, clarithromycin, and amoxicillin? Antibiotic resistance of Helicobacter pylori should be considered. 127. How can persistent H. pylori infection be detected? Persistent H. pylori can be detected using urea breath testing, stool antigen detection, or a repeat endoscopy for biopsy. 128. Can capsule endoscopy detect H. pylori? No, capsule endoscopy cannot detect H. pylori. 129. Why were vagotomy and surgery more common in the past for ulcers? In the past, ulcers were treated with vagotomy and surgery because H. pylori was not known to be the main cause. 130. Why aren't H2 blockers and sucralfate used alongside PPIs? H2 blockers and sucralfate add no additional benefit compared to PPIs and are less effective. 131. What is the next step if DU doesn't improve with initial therapy? You should check for persistent H. pylori and switch to antibiotics like metronidazole and tetracycline. 132. What should be done if a gastric ulcer, EGU, doesn't heal? A repeat endoscopy is needed to exclude gastric cancer as the cause of the ulcer. 133. How is a cure for H. pylori confirmed after treatment? A stool antigen or breath test can be used to confirm that H. pylori is no longer present. 134. What are common causes of treatment failure for PUD? Non-adherence to medications, alcohol, tobacco, and NSAIDs. 135. Why is it important to scope a patient with suspected GU? It is important to exclude gastric cancer because it could be the underlying cause of the pain. 136. What are the key differences between gastric ulcer, GU, and duodenal ulcer, DU? GU pain is worsened by eating, while DU pain is often relieved by eating. GU requires biopsy to rule out cancer. 137. What is stress ulcer prophylaxis used for? Stress ulcer prophylaxis is used for patients with head trauma, burns, intubation, or sepsis with coagulopathy. 138. What is non-ulcer dyspepsia, NUD? NUD is epigastric pain without any identifiable cause after endoscopy. 139. How is NUD diagnosed? NUD can only be diagnosed after endoscopy rules out other causes. 140. When should a patient with NUD get endoscopy? Endoscopy is necessary if the patient is over 55 or has alarm symptoms like dysphagia, weight loss, or anemia. 141. What is the treatment for NUD in patients under 45 years old? Treat with antisecretory therapy, e.g., PPIs first, and only do endoscopy if symptoms don't improve. 142. Is Helicobacter pylori treated in patients with NUD? H. pylori should be treated if present and symptoms don't improve. 143. What's the benefit of treating H. pylori in NUD? Treating H. pylori helps only 10% of patients with NUD. 144. What are alarm symptoms that require further investigation in NUD? Alarm symptoms include dysphagia, weight loss, and anemia. 145. What is a gastrinoma? A gastrinoma is a tumor that produces excessive gastrin, leading to high acid levels in the stomach. 146. How common is a gastrinoma in patients with ulcers? Less than 1% of people with ulcers have a gastrinoma. 147. What symptoms are often seen in patients with a gastrinoma? Gastrinoma can cause diarrhea due to excess stomach acid inactivating lipase. 148. What are the characteristics of ulcers that suggest a gastrinoma? Look for large ulcers, recurrent ulcers after H. pylori treatment, multiple ulcers, and distal duodenal ulcers. Here are the next 20 questions and answers. 149. What is the best test to diagnose a gastrinoma? The best test is to check gastrin levels after stopping antisecretory therapy, PPIs or H2 blockers. 150. What other tests can be used to diagnose a gastrinoma? Tests include high gastrin levels despite high gastric acid output, the secretin test, and checking for hypercalcemia. 151. Which is the most accurate test for gastrinoma? The secretin stimulation test is the most accurate functional test for diagnosing gastrinoma. 152. How do you check for metastases after confirming a gastrinoma? CT MRI have low sensitivity, so somatostatin receptor scintigraphy and endoscopic ultrasound are used. 153. What is the role of somatostatin receptor scintigraphy in gastrinoma? It detects somatostatin receptors on the gastrinoma tumor and helps find metastatic disease. 154. What happens if imaging and scans do not show metastases in gastrinoma? Even with normal scans, metastatic disease may still be present, requiring further testing and monitoring. 155. How is localized gastrinoma treated? Localized gastrinoma is treated with surgical removal of the tumor. 156. How is metastatic gastrinoma treated? Metastatic gastrinoma is treated with lifelong PPIs to block stomach acid production. 157. What is diabetic gastroparesis? Diabetic gastroparesis is impaired gastric motility due to autonomic neuropathy from long-standing diabetes. 158. What are common symptoms of diabetic gastroparesis? Symptoms include chronic abdominal discomfort, bloating, constipation, nausea, vomiting, and early satiety. 159. When is diagnostic testing needed for diabetic gastroparesis? Diagnostic testing is not necessary unless there is a failure of therapy. 160. What is the most accurate test for diabetic gastroparesis? The most accurate test is a nuclear gastric emptying study. 161. What is the best initial test for diabetic gastroparesis? The best initial test is upper endoscopy or abdominal CT to rule out other causes. 162. What does a delayed gastric emptying study show in gastroparesis? It shows that food takes longer than usual to leave the stomach, confirming gastroparesis. 163. What is the best initial treatment for diabetic gastroparesis? Dietary modifications are the first step, including blending foods, restoring fluids, and correcting potassium and glucose levels. 164. Why can't metoclopramide be used long-term for diabetic gastroparesis? Long-term use can lead to side effects like dystonia, hyperprolactinemia, and movement disorders. 165. What should be done if gastroparesis persists after dietary changes? Metoclopramide can be used, but it must be closely monitored due to side effects. 166. What treatment options are available if metoclopramide doesn't work? Other options include erythromycin, antiemetics, or gastric electrical stimulation. Here are the next 20 questions and answers. 167. What is the most important step in managing severe gastrointestinal GI bleeding? The most important step is fluid resuscitation to stabilize the patient before diagnosing the cause. 168. Why is it unnecessary to check for orthostasis when blood pressure is low? If the systolic BP is under 100 mmHg or there is tachycardia, orthostasis indicates significant blood loss. 169. What fluids are preferred when blood pressure is low in GI bleeding? Normal saline or Ringer's lactate are better than 5% dextrose in water. 170. Why is it important to know the sequence of treatment in GI bleeding? Fluid resuscitation should be done before diagnostic procedures like endoscopy. 171. What is the most common cause of upper GI bleeding? The most common cause is ulcer disease, such as gastric or duodenal ulcers. 172. What are other causes of upper GI bleeding? Other causes include gastritis, esophagitis, duodenitis, cancer, and varices. 173. What is the most common cause of lower GI bleeding? The most common cause is diverticulosis. 174. What are other causes of lower GI bleeding? Other causes include angiodysplasia, polyps, cancer, inflammatory bowel disease, and hemorrhoids. 175. How is the severity of GI bleeding assessed through physical findings? Orthostasis, tachycardia, and low systolic BP indicate more severe bleeding. 176. What is orthostasis? Orthostasis is a 10-point rise in pulse or 20-point drop in systolic BP when going from lying to sitting to standing. 177. What percentage of blood loss corresponds to different hemodynamic changes? Orthostasis, 15 to 20% blood loss, pulse 100 BPM or systolic BP 100 mmHg, 30% blood loss. 178. How is variceal bleeding different from other types of GI bleeding? Variceal bleeding has signs of liver disease, like spider angiomata and splenomegaly. 179. What signs suggest variceal bleeding in a patient? Signs include vomiting blood, black stool, spider angiomata, caput medusa, and splenomegaly. 180. What is the most important diagnostic step in acute GI bleeding? The priority is fluid resuscitation, checking hematocrit, platelets, and coagulation tests. 181. What tests should be done in severe GI bleeding before endoscopy? Before endoscopy, focus on fluid resuscitation and checking blood counts. 182. What is the role of a nasogastric NG tube in diagnosing GI bleeding? The NG tube helps rapidly identify upper GI bleeding and determine if upper endoscopy is needed. 183. How effective is the NG tube for identifying upper GI bleeding? The NG tube has 70% sensitivity for detecting upper GI bleeding. 184. What does it mean if the NG tube aspirate contains bile? Bile indicates the bleeding is definitely from the upper GI tract. 185. If a patient with cirrhosis has black stools but no vomiting blood, what can an NG tube reveal? The NG tube may suggest variceal bleeding, requiring octreotide. Here are the remaining questions and answers. 186. When would an NG tube be unnecessary? If an upper endoscopy is already planned, the NG tube has limited benefit. 187. When is a nuclear bleeding scan used? A nuclear scan is used when endoscopy does not reveal the source of massive acute hemorrhage. 188. When is angiography necessary for GI bleeding? Angiography is used to identify specific bleeding vessels before surgery or embolization. 189. What is capsule endoscopy used for? Capsule endoscopy is used for diagnosing small bowel bleeding when other tests fail. 190. When are CT or MRI scans helpful in GI bleeding? CT and MRI scans are generally not useful in diagnosing GI bleeding. 191. What role does EKG and lactate level testing play in GI bleeding? They can show ischemia due to severe blood loss. 192. What is the primary treatment for acute severe GI bleeding? Fluid replacement with high volumes of saline or Ringer's lactate. 193. When should packed red blood cells, PRBC, be transfused? PRBC should be transfused if hematocrit is below 30 in older patients or those with heart disease. 194. When is fresh frozen plasma, FFP, used in GI bleeding? FFP is used if the PTINR is elevated and there is active bleeding. 195. When are platelets transfused in GI bleeding? Platelets are transfused when the platelet count is below 50,000 ml and there is active bleeding. 196. What is the role of octreotide in GI bleeding? Octreotide is used to treat variceal bleeding by decreasing portal pressure. 197. What is the purpose of endoscopy in GI bleeding? Endoscopy determines the diagnosis and allows treatment like banding varices or cauterizing ulcers. 198. What should be done if GI bleeding cannot be controlled with fluids, blood, platelets, and plasma? Surgery may be needed to remove the source of bleeding. 199. What treatments are used for variceal bleeding besides fluids and blood products? Octreotide, banding of esophageal varices, and TIPS procedure. 200. What role do propranolol or nadolol play in variceal bleeding? They help prevent future variceal bleeding, but don't stop active bleeding. 201. Why are antibiotics used in variceal bleeding? To prevent spontaneous bacterial peritonitis in patients with ascites. 202. Why is sclerotherapy not used for variceal bleeding? Banding is more effective and safer than sclerotherapy. 203. What is antibiotic-associated diarrhea, AAD? AAD is diarrhea that develops after taking antibiotics, often due to Clostridium difficile overgrowth. 204. Which antibiotic is most commonly associated with AAD? Clindamycin has the highest incidence of AAD and C, difficile infections. 205. Can any antibiotic cause diarrhea? Yes, any antibiotic can potentially cause diarrhea. 206. What are the symptoms of antibiotic-associated diarrhea? Diarrhea starting days or weeks after antibiotics, with possible blood or white cells in stool. 207. What is the best initial test for diagnosing C, difficile infection? The best initial test is a stool, C, difficile toxin test, or PCR. 208. What is the most effective initial treatment for C, difficile-associated diarrhea? The most effective initial treatment is oral vancomycin. 209. What should be done if there is no response to oral vancomycin? The next step is to switch to fidaxomicin. 210. How are recurrent episodes of C. difficile-associated diarrhea treated? Recurrent episodes are best treated with another course of vancomycin. 211. When is intravenous IV metronidazole used for C. difficile infection? IV metronidazole is used only if oral therapy cannot be used, such as in ileus. 212. Why is stool not cultured for C. difficile? C. Difficile does not grow well in culture, making stool cultures ineffective. 213. Is endoscopy necessary to diagnose antibiotic-associated diarrhea? No. Endoscopy is not necessary since a stool toxin assay is available. 214. Why is intravenous vancomycin not used for antibiotic-associated diarrhea? IV vancomycin cannot reach